Hi, it's Professor Cassidy, and in this video, we're going to go over acute decompensated heart failure for adults and for pediatric patients. If you haven't already watched the first video just on heart failure, please go watch that because that goes over the disease process, compensatory mechanisms, signs and symptoms, diagnostics, and medications. So you'll need that information to understand what's going on in this video. Okay, so here's a couple of patients. This is how, if you're decompensated, this is how you might look. You're having a hard time breathing. If you're having left-sided heart failure and fluid is backing up into your lungs. And if you're having right-sided heart failure and fluid backing up into your body, you're going to have all this edema throughout your body. So, specifically when these patients come into the ED, they'll have like a hard time breathing, they'll be dyspneic, they'll be orthopneic, they'll also have a high respiratory rate, high heart rate, and hypertension. Those are all common symptoms of somebody who is fluid overloaded and in acute decompensated heart failure. Now, if it has gone, if they're really sick, if they're even sicker, they could be hypotensive, and that's when they're going into shock. So people who are having congestions in their lungs really bad, they could use their accessory muscles, and that is just to try to really help get that oxygen in. Now, your diaphragm's not enough, you're using accessory muscles as well. Also get to hear some crackles in your lungs, and you'll hear that that S3 heart sound, the ventricular gallop, where that extra fluid is rushing back into the ventricle when the valve opens up, and it creates that X3 sound. So when they come, we definitely want to do an EKG and see what their rhythm is. They may already have a diagnosis of AFib and be on medications for that. So we'll check for that to see if there's new AFib. Also, they're at risk for ventricular tachycardia or ventricular VFib. So we want to make sure that we do an EKG and then we put them on telemetry. They should have cardiac monitoring while they're in the hospital. We'll do a chest X-ray also, just to see if there's congestion in their lungs, see if there's cardiomegaly, look at the size of the heart. They'll do labs, the complete blood count. They will do a trope to see if there's any, the patient could have increased workload of the heart. They're having increased workload of the heart, so they might have symptomia and ischemia, and that would be, they would have a bumped trope if that were the case. Also, their electrolytes may be off. They want to check their kidney function. If they're in, if they are in respiratory distress, we definitely would want to get an arterial blood gas too, liver function tests, and then the BNP, which is the brain natriuretic peptide. That's an enzyme that is released when the ventricle stretches out. So we can measure that in the blood, and that, along with the patient's presentation, is used for diagnosis of heart failure, of decompensated heart failure. They also would do an echo to see, just check blood flow and valve function and ejection fraction. Okay, so the goals of treatment, remember the goals of treatment for people who have heart failure that they're managing at home are to reduce morbidity, which is like the symptoms and the quality of life, and reduce hospitalizations. So reducing morbidity and reducing mortality, which is premature death from heart failure. Those are when they're outpatient. When they come to the hospital, the goals and are to hemodynamic stability, make sure that they are adequately perfused and their oxygen is good and their blood pressure and mean arterial pressure are supporting this, and that they have symptom relief too. If they're like, really fast respirations and have an air hunger, that's very uncomfortable. So we want to make sure we are supporting them and relieving their symptoms. Once they're stable, we're also going to optimize their fluid status. That will start in the ER, but that will continue throughout. We're kind of figure out, why did this happen? What were the precipitating factors? Address those so that it doesn't happen again. Again, work towards optimizing the guideline-directed medical therapy so that to get their heart working as most effectively as you can with those medicines. Prevent hospital-acquired conditions as well, which is, blood clots, pneumonia, other infections, things that you're at risk for when you're in the hospital, and patient education, support, and self-management. These are the goals of care for acute care when they're in the hospital. So I have another, this box here again, and these are throughout the slideshow, just to kind of help you focus in a little bit. So I wouldn't want you to, I do want you to know these things, but I don't want you to worry about having to know that symptom relief is under initial goals versus ongoing goals. These are all things that are going to happen in the hospital. I don't want you to try to memorize this as a list in any order. Just understand that this is what we're doing, the goals that we have for the patient. Okay, so this slide, oh, and there's the yellow box here. I want to talk about these different. I know the book talks about dry if you have normal fluid level, wet if you are hypervolemic, warm if you have good perfusion, and cold if you have poor perfusion. So I just wanted to go over and look at, a patient with each one. I don't want you to look at these treatments. They're beyond what we need to know, and I will go over treatments next, but I just wanted to, I like this picture. And I like the way it kind of puts them together. So if you're dry, you're not fluid overloaded, and you are warm, you have adequate perfusion, then you are at home doing really well. So your heart failure is being managed. Now, if you're wet and warm, then you have fluid overload. You're wet, but you're warm, you still have adequate perfusion. So you might be symptomatic to the point where you have to come to the hospital, or you might be at home and your doctor prescribes more diuretic for you. But if you get too wet, then you're going to have to come to the hospital to get IV Lasix for that, or IV torsemide. If you're wet and cold, now you're fluid overloaded, but your heart has having to work so hard that it now just really is in severe failure, and you're in shock at this point. You're not perfusing. So you have decreased cardiac output. So that is treated very differently than just trying to diurese you. And then if you are dry and cold, you're not fluid overloaded, but you're just not perfusing anymore. Your heart really just isn't working. Okay. So the treatments are, and the things that I circled in red, you definitely should know that these are treatments that we'll be doing for our patients when they're in hospital. We're going to monitor their oxygen sat, monitor their vital signs. They should be on telemetry. We're going to give them supplemental oxygen if their SpO2 falls below 90%. It's a good idea to give them 2 catheters. They're pretty sick. I mean, 2 IV catheters, they're pretty sick. And keep the patient positioned upright. We wouldn't want to lie these patients down. Initiating diuresis really, to get that extra fluid off, is really important too. You could come in and only need these treatments up here, only need as much as diuretic therapy. But if you are needing more support, you're sicker than just needing some IV loop diuretics, then we'll look down here. Now, as far as looking at what treatment plan we're to go, I just wanted to explain to you, if you come in and you are wet and warm, so you have extra fluid, but you are perfusing, you're normotensive or you're hypertensive. You're probably hypertensive because you have all this extra fluid in you. We're going to diurese you. We're going to give you a loop diuretic, but we're also going to vasodilate you to just relieve some of that afterload. So we're going to give you nitroprusside or nitroglycerin IV to try to relieve some of that after load. Now, if you do not have, if you still fluid overloaded, but you don't have adequate end organ perfusion, so you're hypotensive or you're shocked, like your mean arterial pressure is less than 60, your blood pressure is low, you're not perfusing. So it depends on what the mechanism is. Do you have a problem with pumping, or do you have a problem with filling? So if you have HFrEF, which is systolic dysfunction, and you are not able to pump adequately, then we are going to give you an inotropic medication, Dibumine or Melrone, and that is to help you pump to get that blood out. I'm going to stop the beta blocker because the beta blocker slows down your heart rate, and we don't want it to slow down. We want it to go at a nice pace, and to be able to get that cardiac output increased. Now, if you have known HFpEF, which is diastolic dysfunction, and that is a problem with filling, we're not able to fill, and you are you have inadequate end organ perfusion, so you have really low blood pressure. I'm going to give you some IV fluids because that fluid is not making it back to your heart. I'm going to give you vasopressors so that we can again get fluid back to the heart, and that would be like norepinephrine. And also, we're going to give you a beta blocker to slow your heart down and increase the contractility and allow time for filling. So those are the different mechanisms of how we would treat patient based on fluid overload, hemodynamic status, and what the mechanism of problem is with the heart failure for left-sided heart failure. Okay. So we're going to get into nursing care a little bit while people are in the hospital. And I like this slide because it talks about, we used to say that patients should be compliant. And that is, I am the healthcare provider or the healthcare, the person, and I know what is best. I have all this evidence. We know what works, and I'm going to tell it to you and expect you to follow those. And that is compliance. So we moved away from that because we understood that it was really paternalistic and most patients didn't react to it, although some did. And we move towards adherence, which is we're going to get together. I'm going to educate you. I'm going to make you informed about what's best. And you're probably going to agree to do that while we're together in the office or at the hospital when we're having this session. And then I'm going to expect you to adhere to that plan. So that still is a little bit not completely respectful of the patient and what they might want. So really what we have moved towards, and this has been, nursing care for a while, is concordance, which is more, tell me what's important to you. Here's some information, but how does that affect you? What do you want? So for instance, like if I were to tell a patient, if I'm educating them about doing their daily weights at home. So get up in the morning, every morning, go pee, weigh yourself, write in a calendar, keep track of it. If you gain more than 3 pounds overnight or 5 in a week, call your provider. And this is how we manage it at home, right? So that one thing, so I could be compliant, expect compliance since I'm telling you this, you do this. Or I could say it and say, do you understand? I use the teach project method, try to, make them really understand the importance of it, show them the benefit of it, but then also expect that they would adhere to it. Versus concordance, I would say, okay, so tell me, this is what we know is, a way to manage heart failure. Tell me about like your day. Does that work for you? What's going on in your morning? Are these things you're able to do? And it might not work for them. We might have to find a different way to do it. So that's concordance. Okay, so for diet, I'd like to teach this for diet education, not just for low sodium. We recommend low sodium for patients who have heart failure as a diagnosis. But for any diet education that you're doing for a patient, if you're trying to teach them to do low saturated fats or if you want to increase their fiber, using the nutrition facts label is a really great way to do it. And instead of having them count like the different number of nutrients, they can just use the percent daily value. And the things that, and I love this image too, because it shows the things that we really should be eating less of. And if you choose things that are 5% of less, any nutrient that has 5% or less on this label, it's low in that nutrient. And anything that there's 20% or more, it's high in that. So if you just tell patients when you educate them, if you try to find foods that have percent daily value that are 5% or less, you know that those are low in sodium and those are healthy foods for you in that one area. So, and I tell patients, just go home and look at the food that's you already have. Look in your cabinets, look in your refrigerator, your ketchup, your salad dressings, all of those things, and look at those labels. We tend to buy the same food over and over, so you can just do this at home. And then they can, and they can take their time and do that over a large chunk of time, but then they are aware of what foods are really high in sodium and which aren't. And then they might say, well, this is high in sodium, but I'm not willing to give that food up. And they might eat it less frequently, or they might substitute it. Multiple studies show that just reading food labels, just the act of reading food labels, makes people choose healthier food. So it's an easy way to do it. It's something they can do at home, and it's been proven to work. So that's how I recommend you approach diet education. Okay, so preventing hospital-acquired conditions, and those are things that happen just from being in the hospital, which is a really dangerous place for patients to be, even though, so you don't want them there a second beyond longer than they need to be. So pressure injuries, falls, I think those are common ones that you would be aware of already. So withdrawal is not one that I've seen spoken of or thought of a lot in this sense that you can have a hospital as a hospital acquired condition. So I know you've done the section on alcohol, so you're aware of how dangerous that could be. And on day two, really, if somebody's used to drinking alcohol, they could go into severe withdrawal. But people also withdraw from caffeine, they withdraw from nicotine, and they withdraw from other substances. So, and they might not recognize, like if you have somebody who smokes cigarettes, and a lot of times, frequently when people are in the hospital, they're able to just turn off the cravings because they know they're trapped. Not everybody can, but a lot of people can. So they're not having the cravings, or they're, just nowhere near what they are at home. So they don't recognize that they're withdrawn from nicotine, but they are. So if they're more irritable, their heart rate may be a little higher, they're just, feeling anxious, being cramped up in their room. Those are withdrawal symptoms. So if you have somebody who is going through that differently, that affects their healing. It's harder for them to be in the hospital. It's harder for them to be educated. Just get them a nicotine patch. And the same thing with caffeine. We're not going to give people caffeine in the hospital, probably, not if they're there for cardiac issues. But recognizing that they're having the withdrawal symptoms, that they might have headaches, they're used to getting the kind of jolt to wake them up and give them, keep them awake. So just recognizing that is going on, and understanding and talking with your patient about it. Other hospital-acquired conditions include VTE, such as a DVT or a pulmonary embolism, and we know that people should be moving so that this doesn't happen, and they should be on prophylactics, antibiotics like Lovenox or heparin. Definitely at risk for pneumonia, other infections, muscle atrophy, and constipation. And all of those things mostly can be, you can reduce the risk by getting your patient up and moving them. If they are not able, if they have an order for bed rest because they need rest, then that's different. But other than that, they really should be, getting up, sitting up in bed, sitting in the chair, walking if they can, to really reduce the risk of these things and to maintain their muscle and balance strength. So weight loss is also when people are in the hospital, and it feels counterintuitive because they're not moving as much or kind of laying around. But when you're sick in the hospital, you have higher calorie needs. You need more protein and everything. Your body's using a lot of calories to heal and in the illness that it's going through. So we really want to set up the room to encourage them to eat, let them have their food choices, make sure they're sitting up, get the urinal off the table while they're eating. Get them up to the chair for meals, things like that. It's really important to address these. Okay, and then recognizing other things whether they're in the hospital that you can make consults for your patients, such as a dietitian. If somebody is, I don't know what meals to make, I don't know how to eat this, or I'm on a budget and I'm not sure how to do that. You can just have the nutritionist or dietitian come in and talk with the patient. Definitely physical and occupational therapy if they've been in the hospital for a couple of days and they're somebody who's elderly and they're really losing that function quickly, they should see PT and OT. If they're not completely understanding their medications, or they're worried about interactions, or there's somebody who's taking supplements at home, you can ask the pharmacist, or you can put in a consult pharmacy and have them come up and talk with them. Social worker and case manager for any problems at home, and for discharge planning. So, so when they're discharged, they'll be discharged in either one of three things. We're going to curative care. We're going to continue to give you medicines to optimize your physical function and with these medicines. Or palliative care, it's you have been in the hospital quite a few times, you're really not managing well, symptoms are a problem, and they've really affected your quality of life. So the goal of palliative care is to really reduce those symptoms and improve your quality of life. And then hospice, this is when a provider recognizes that a patient has 6 months or less of life, and they can go into hospice care. And that is a program that supports the patient and supports their family in their last few months of life, to help them have a peaceful and dignified end of life. Okay, pediatrics. So pediatric patients, when they have heart failure, is mostly related to a congenital heart defect. So they were born with a structural problem in the heart. And they can also get it from increased demand on their heart related to sepsis or severe anemia. But it's usually related to a heart structural defect. And they have the same signs and symptoms as adults, but there are a few that are specific to infants I wanted to go over with you and you should be aware of. So sweating is one of something that occur in a lot of usually sweating on their scalp, and that is related to the cholinergic effect from the activation of the sympathetic nervous system. They can also have retractions, which is when the tissue between the ribs, it sucks in when they're really using those muscles because they're hungry, and they'll get that easier than adult would get that. They also do the flaring of their nares and that grunting. All of those things are just trying to get when they're hypoxic and they're trying to get more oxygen in. And then also for edema, one thing that is common for them when they have the fluid overload is they'll get periorbital. They'll get the fluid around their eyes. So goals of treatment are similar to with adults. We want to improve cardiac function, improve cardiac output, optimize the fluid that they have in there. So we're removing the extra fluid, decrease their cardiac demand while they're healing. Certainly if they have a cardiac heart defect, then we want to decrease their cardiac demands and improve their oxygenation. Frequently, when they're in the hospital, infants are being stabilized, and just the treatment is surgical intervention. So they're stabilizing until they're well enough to have surgery. Okay, and the treatments are the same medications, really just on pediatric doses, and that is to improve cardiac function and correct the balance. As far as decreasing cardiac demands, we want to be super specific with infants and children, especially younger ones or ones without a lot of weight. We want to keep the room temperature warm so they're not shivering, because that does increase cardiac demand. Reduce their metabolic needs. We want to treat infections earlier. Keep them setting up in a semi-collar position to reduce the effort of breathing. And if babies are irritable and they're not able to be comforted, or children, then they will sedate them, really just to reduce that amount of work on the heart, and also decrease in the environmental stimuli, just keeping it calm. So we give them supplemental oxygen. It's like adults. We'll count the respirations for a full minute when they are at rest, and you can just get that even count. And also you want to make sure that you keep them elevated when you're holding them and when they're in bed. So you can see like this image here, the mattress is up and the baby is not laying flat. Make sure the mom has time for feed, or the dad has time for feeding, alternating with rest periods. they also have increased caloric needs. They're sick, they need more protein, their bodies are working harder, they need more calories. So it's really important that they get those calories, that they have the rest and then the feed, the rest and then the feed. They're fatigued, so they're not able to eat as much, but it's important to offer it to them frequently in short spouts so they do get enough. Also supporting the family, so supporting the infant, supporting the child to make sure that they stay calm, but then also supporting the family because it's very stressful. And if they are stressed out, of course, the child or infant is going to pick up on that as well. And that's all. These are my references. And this is my contact information. Feel free to email me or book an appointment, or you can grab me before or after class if you have any questions.